talk. Now I would invite for the keynote address Dr. Peiter Saunte. He has come all the way from Denmark to present his talk on torsional diplopia, assessment and treatment options, including the patient perspective. And he has a specific interest in pediatric ophthalmology, strabismus, neuro-ophthalmology, oculoplasty, and trauma. So, Dr. Peiter Saunte, for the talk, please.
Thank you for the nice introduction. And thank you for letting me come to wonderful India again to share some of our thoughts on what we work on. Could I have my slides, please? So I know an Indian love song. I will not sing it for you now, maybe another occasion.
Can we have his slides, please?
I prefer the slides. So while we wait for the slides, what I want to share with you with this talk is how patient sees torsion. See if they have torsional diplopia, how does it affect them, and what should we listen to try to understand what's going on. So I've tried to make some TED Talk. Yeah, we'll make it. I'll draw some figures on the wall somewhere. But torsion, I think one of my residents, very talented resident, he missed the torsion. The patient had perfect vision, had some complaints going down, and everything was fine. So why should we do anything with this case? And the patient had torsion and suffered from that. If it's better with the program to change the row of speakers, I can take this later during the day, whatever works with you.
Audiovisual guys, can we have a talk, please?
I can use my stick directly on this computer. Does it work?
So audiovisual guys probably have a little bit of torsion. Finding it difficult to...
I'm sorry?
I mean, the guys are having torsion.
Yeah, something's torted somewhere.
Not able to sort it out.
It's fine, no problem. So I traveled to India in 1993 as a medical student and stayed 3 months in a hospital in South India, which completely changed my way of thinking. I was thinking to be a cardiologist at that time. There was a very, very famous cardiologist working at that hospital, so I wanted to visit him. But at that same hospital, they also had an ophthalmologist which did cataract surgery, and she was turning blind people into seeing. And that changed my career, so I wanted to be an ophthalmologist as well. So India changed my life career actually in ophthalmology, which I'm very thankful for.
He has a pen drive. He can use this laptop.
Should I take it from this? Oh, something's happening.
Can you please come here and help him put his...
Shall I come to your place? I can give the talk from there. Oh, this looks great. So we can run from now? Okay. So when I want to change the slides, do I use the screen here? Yeah, here. Okay, now we go. I have a interest conflict, so it's not interesting for us. So how do the people experience torsion? So this is this is India this morning, and if you have 5 degrees of torsion, this is what you may experience. This is 10 degrees, and this is 15 degrees. So 15 degrees of torsion is quite disabling for all of us. So how can we treat this? And this is the patient I mentioned before, fell on the bike in Copenhagen. She was drunk, and she had a bad brain injury. Her eye workup was normal, and we saw her 6 weeks after the trauma in our clinic. She was ortho in primary, but a down gaze ET, and she has a left hyper on right gaze and right hyper on left gaze. So this is, and she also had excyclotorsion, worse as down gaze, and this is what's going on. She has excyclotropia, so the eyes are excyclotropic due to bilateral fourth. So we wait, we see what's going on. We wait 9 months, and she is still symptomatic. Down gaze is a problem, and we wait 16 months to see if this goes away. We ask her, how are you doing? Well, she says, I'm better now, but at down gaze I have big problems. Reading is a problem, walking, making food. She cuts her hands when she's cooking, and this is why she doesn't drive a car anymore. So her life, the world is twisted for her. And when she reads on top of the screen, everything is fine. When she looks down, this happens. So she has a torsion on down gaze, and we tried her, can't you show us how this works? So we took these 2 pieces of plastic, put them on top of this other. This is one each eye, each figure. And I asked her, can you show us how is your world, what do you see? So now she's showing us her double, and it's twisted and it's vertical and horizontal deviated. So when you have torsion diplopia, there are many reasons for this, we know this. So we want to take care of this problem, and instead of having pure torsion, you can even have a situation where you have a unilateral fourth, and to compensate for this, you tilt your head. And if you have a unilateral fourth, you will actually have both torsion and vertical misalignment. So what do the patient complain about? They complain about blur, so this is what they can experience. Things are a little bit blurred. It may be difficult for them to explain for us how does the world look for them. And they have all kinds of problems related to torsion. We can try to assess this in many ways. Maybe the synoptophore is the golden standard for most of us, but other tests out there are very useful. And especially the screens where you can test torsion in different directions are of value. So what about treatment? What can we do? We can patch them. We can do the surgery, and when we do the surgery, we want to use a microscope. And the microscope makes it easier to find these small details, and we use small tendon hooks. If you want to use adjustable sutures, opening away from limbus is nice because the sutures won't pop out in the opening for you. And if you have a surgery on superior oblique, remember there's a little tendon between the superior rectus and superior oblique. You cut it, and the barbier retractor gives good overview for you. Cutting the tendon, what suture should we use? Well, we usually go for Vicryl 6 sutures when we suture to the eye, but if it's not attached to the eye, we use a non-absorbable suture. And if you want to take care of excyclotropia, what to do to take care of this? You can tuck it. And when you tuck the tendon to avoid inducing a brown, you need to do the repeat force reduction testing to see if you have created a Brown syndrome. Harada Ito may actually produce hypotropia, so if you split the tendon posteriorly, you will take care of that. And many ways to do this technique are discussed, and I know Eric Boton will discuss this a little bit later, so I'll just skip a few of these slides. We know that when we tighten the superior oblique, this will stretch, it will unwind, and during the first week, it usually unwinds up to we found up to 10 degrees for a week. And Jonathan Holmes found that if you do a unilateral Harada Ito, you should overcorrect it 7 degrees because that's what the unwinding you're expecting. And during the surgery, you can actually put some, drawings on the table, and then you can, when you measure, you can put the instrument aligned with the drawings on the draping, and then when you have the blue dots on the cornea at 6 and 12, you can see how much torsion do you induce during the surgery. So adjustable sutures will help you to do what you want to do, to dare what you want to do. So we tighten the supraoblique, and we can unwind or change the tightness with adjustable sutures, which are hit on the conjunctiva afterwards. So let's go back to our bike accident before. She had a double bilateral Harada Ida performed. This was before surgery, big excyclotropia down gaze. And after surgery, these were taken care of. And we asked her, how does your double look like now? So up gaze, there is a little overcorrection, so he has incyclo, but in primary gaze, pictures are aligned, and at down gaze, things are also working well. So when she wants to read important text, when she reads down this text, everything is fine. Other surgeries for excyclotropia, we can work on the inferior oblique. We can make that an intortor. And the group from Delhi has looked at what happens if you make the inferior oblique, you put it nasally. If you work on the inferior oblique, this will take care of maybe 3 to 6 degrees of torsion if you put it temporally, but if you put it nasally, you will have a big effect to correct the excyclotorsion. The group in Japan has looked at a lot of inferior rectus nasal transposition to take care of torsion, and they found that if you do this unilateral, it takes care of 6 degrees, and in bilateral, it takes care of 11 degrees. And if you have encyclotropia, which is the last thing I want to discuss with you, if the tendon is too tight, like in Brown syndrome, encyclotropia, you want to avoid the double day experience, then you can, after the force duction testing, when you press the eye into the orbit, and excyclo and encyclo rotate the eye, then we put the numbers on the wall and the whiteboard, and we cut the tendon. And just a few notes about this. We use this nice little tool which holds this tendon for us. And we know that this is a quite an unpredictable procedure, so we have developed a suture where I just want to skip you to the pictures here. We have combined sutures with a chicken suture and this short tag noose suture. And if you do that, you can have an adjustable supraoblique suture, which is actually adjustable. And this is how it looks in real life. It's a Merslin suture with a vitral noose, and this will allow you to adjust the suture up to a week after surgery. So this is a case from before. Has a right hyper and right gaze. And we make a 4 millimeters chicken suture. This was not enough, so we increased this to 8. And after last adjustment, he is ortho and side gaze, and head tilt is corrected as well. And we found that the torsion effect from the spacer effect is up to 5 degrees per millimeter spacer. It depends upon how many millimeters you prolong it. So in conclusion, torsion, the symptoms are invalidating for the patients. The assessment can be done by many different techniques synoptophore, but we need to help these patients by surgery. Thank you.
Thank you.
One last comment. I'm sorry. So yes. So this is I'll just share one thing with you, because all of us who do strabismus surgery, we might have nightmares when we do the wrong surgery on the correct muscle or vice versa. So if you have a planner in your OR and write the plan in the room, everybody can see it. You double check it through this several times. You will be sure you won't have nightmares about your own surgeries. Thank you.
Thank you, Dr. Peiter Saunte, for such a nice talk and making us aware how the patients feel in case of diplopia they have. And thank you, everyone. Thank you, all the speakers, for this session.